Provider enthusiasm around accountable care organizations, cost for implementation, performance measurement and impact on healthcare delivery. How might accountable care organizations create a paradigm shift for healthcare? And practically speaking, what do providers, manufacturers, payers, and patients need to do to prepare? Join us to find out. In the Know starts now. Hello and welcome to In the Know, your source for insight and analysis on the issues that matter to our dynamic healthcare market. I'm your host, Gina Clark. Today we explore the ongoing discussions around accountable care organizations. Specifically, we will see how ACOs have progressed from a public policy perspective over the last 6 months and how providers are responding to the cost and practicality of ACO participation. We will also discuss how ACOs might change the way manufacturers interact with prescribers. Joining us for today's talk is Loreen Brown, Vice President of Access and Reimbursement for Xcenda. Loreen, thanks for being with us today.
My pleasure. Thanks for having me.
So Loreen, from a legislative or policy perspective, how have ACOs progressed in the last 6 months? And what do you expect will happen on that front by the end of 2011?
Well, the proposed rule for the ACOs came out on March 31st, and the comment period for the ACOs ended on June 6th. However, shortly thereafter, there were 2 other initiatives, the Pioneer ACO and the Advanced Payment ACO, that came out, likely in response to much of the criticism that the original proposed rule, all 429 pages of it, that it received. Now, those 2 models are really looking at different avenues to get the ACOs jump-started, and which is a good plan considering there will likely be an interim rule that comes out where CMS takes a look at some of the 1,200 comments they've received and provide feedback to the stakeholders for them to again provide comment. So since this comment period is going to go back and forth a couple times, it will likely go into 2012. The other ACO model, the Pioneer model, now that will likely start sooner as it's really focused on groups that are already doing accountable care organization type programs with private payers, and they expect those to kick off this fall.
CMS will award bonus payments to providers who affiliated with high-performing ACOs. Can you discuss how CMS will measure performance and the degree to which you believe these benchmarks can be practically achieved?
Sure. Now, there are 2 different benchmarks that CMS will use. Now, keep in mind this is a proposed rule and they could change, but right now there are 2 benchmarks. One is based on quality, the other on expenditures. And the quality measures are based on 65 different qualities that we've heard a lot from the stakeholders. They think that's too many, that it's too prescribed. However, they do focus on 5 specific areas: patient and caregiver experience, coordinated care, preventative care, at-risk, high-risk, folks who are either frail or have chronic conditions, and patient safety. Now, if you think about those are measures that we would want folks in our healthcare industry to measure and take care of. But is 65 too many, and what are those 65? For example, the oncology measures are only 2, and they're not based on treatment, they're based on screening only. So when you think about those measures, have we really captured the right measures? On the expenditure side, that benchmark will be set by CMS looking back 3 years at the most recent payment for Medicare Part B and Part A claims. Now, the problem with that is that Medicare Part D claims will not be included in there. So that does perhaps put some strain on whether you use an injectable or physician-administered drug versus an oral drug.
How receptive have providers been to participating in ACOs?
Well, as I had mentioned, there were lots of prescriptive rules that were provided in the proposed rule. And back in January, before the proposed rule came out, the Healthcare Finance Management Association did a survey of its members, and at that time about 2/3 were either going to participate or planned on leading an ACO. Now fast forward to May, and the American Medical Group Association actually did a survey, and only 7% of their members actually were willing to participate given the proposed rule. And if you think about that group, there are members such as Geisinger, Dartmouth, Hitchcock, the big groups that participated in the demo program that actually built the ACO model that have a lot of reservations. So it'll be interesting to see how this proposed rule turns into perhaps an interim or a final rule, and if CMS can react to some of the comments that the stakeholders have proposed and turn it into a model that more providers will be interested in participating in.
To what extent do providers' costs weigh into their decision on whether to participate in an ACO? And what type of investment are we talking about? And how much of that could be considered at risk if the ACO does not perform well?
Well, the cost depends on where the ACO is at the moment. Now, if you have an electronic health record that your organization is using and using well throughout that group of providers and hospitals, then you're probably in pretty good shape. However, if you don't and you really need to build that infrastructure, that costs quite a bit of money. CMS estimated that the average ACO would spend about $1.75 million. However, the American Hospital Association and others have done numerous surveys, and they have estimated that number to be 11 million or even up to 26 million, depending on how much needs to be built. So it really is a very expensive proposition. When thinking about what's actually at risk, I think that's kind of a tough question, because inevitably, if you are using these models that are supposed to streamline efficiency and increase quality, you most likely will decrease costs and eventually recoup what you're spending. Also, many of the pieces of the ACO, the EHR, the electronic health record, the increased coordinated care, the focus on quality, all of those things that are things that are necessary to happen in order to keep our healthcare system afloat. So the risk is almost higher if they don't implement these types of things.
Are there steps that the providers can take to mitigate their risk when participating in an ACO?
Well, there's lots of legal ramifications, obviously. So we always suggest that folks talk with their legal advisors to ensure that they're not getting into something that they can't handle. But typically, you are really looking at being able to coordinate care among a group of physicians and specialists and hospitals. And if you can do that in a fairly expedient manner and you have those systems in place, then the risk does become less. I think the other piece to look at is being able to utilize your data. Comes back again to the electronic health record. Data is going to be mentioned over and over because you really need to know the population you're looking at. What are the highest cost conditions that these patients within that system bear? What type of interventions are typically used? Which are the most expensive? If you could really analyze your data and understand your population, then you can figure out which tools you need to actually help those patients to decrease costs and improve quality.
So all ACOs are required to use electronic health records. How do you think this requirement will affect ACO implementation, both in terms of how long ACOs will take to implement and how prevalent they will be?
Yeah, I think that it all comes back to what you currently have today. If you have a system that works and can really integrate with the other groups that you're going to be part of your organization, then you're in good shape. However, I would say the number of really truly accountable care organizations that exist today are not that many. So you may have an electronic health care record, the hospital may have one, your specialist may have something else. You need to have a mechanism where all of them speak together in the same language, and that takes time. And that's one of the complaints actually of the proposed rule, is that these ACOs under the Medicare program are supposed to be up and running by January of 2012. And really to integrate that healthcare system with the correct EHR systems takes time and expense.